All righty. Good evening to everyone. If you would, go ahead and place your name and campus in the chat. And here we go. Make sure we're recording. So we're going to go ahead and jump in. So hopefully this is repetitive for you and that file cabinet drawer, so to speak, opens up and when you hear a term, oh, okay, I know what that is. Oh, right off the bat. So hopefully, but again, as you make your list with those things that those terms and concepts that you're least familiar with. And again, these slides are in your slide deck. I just added pictures and I spaced things out and I added me some questions off inside. So it's not anything that you don't have. I just like the different colors and everything. All right, so we're going to first start off. I want to hear from you. We're going to actually give you 5 minutes to do this. So on paper, just jot note, and then throughout class tonight, we will call on you to. So if you want to have your chance to tell us and talk to us about your three top healthcare settings. So by now, you should have rotated, even if it was a simulation, through different healthcare settings. What were your top three? So you're going to jot those down. And then just think about what is your why? Like, why were those your top three? Why was it, maybe parish nursing? Why was it when you went to school? Why was it, why? What is your why? What is that organizational structure in that setting? For your number one healthcare setting, what did you think about, or did you look and see, how things were run and how how the day to day, the shift to shift actually ran? So tell me about that organizational structure within that setting, your top one. And then again, add what could make the setting better for the patient and staff. Because we're always in this mode of providing the latest, best evidence-based information. So we're always trying to revise for the better. So what could make the setting better for the patient and staff? So on your paper, we'll get everybody a chance to go and we'll weave you in as we go out throughout tonight. So I'm gonna actually pause and we put my timer on, probably 5 minutes to actually do this. I'm gonna leave this on the screen, and then I will randomly let you volunteer, but then everyone will still get a chance to go before tonight is over. Let me do the timer here. So 5 minutes. But for the organizational structure, you're just listing this for your number one setting. If you have two that are competing for number one, that's fine. Just think about the structure of it. What did you see, or what do you think you know about that structure? Okay, so I'm gonna go on mute and let you think through it, and then the time starts now. Okay, 3 minutes left. 3 minutes. Okay, 1 minute, 40 seconds, and we'll hear from you here soon. All righty, we have about 30 seconds left. Be deciding if you want to just go ahead and volunteer. Let me hear from at least two people, but we'll stop and start throughout tonight and we'll give everyone a chance to share. But right now we can take a volunteer. Who wants to tell us their three top settings, healthcare settings, and then, what is your why? Why, why are those settings your top three? Because there's a whole bunch of them out there, a lot of settings that we can actually work in. And
I'll
then,
volunteer.
okay, is that Miss Davis? Oh,
Yes.
all right. The floor is yours. I will mute myself. Go ahead.
Um, one of my top three. Do I have to do all three?
Yes, you tell us your top three, but then
Okay.
the others you just work through one.
Okay. My top three would be urgent care, memory care, and long-term care. I would do urgent care because I like the fast-paced environment and being able to take care of patients with different needs. You said the structure. What is it? The structure would be nurses, front desk staff, and probably like the medical assistants.
Okay. And then some type of provider, nurse practitioner,
Yes.
MD, some type of provider. Yes.
Um, you said just one, right, or all three?
No, your top one, you talk about
Okay.
what can make, then the last thing, your top one.
Oh,
What do you think can make that city better?
they can have more staff
Okay. So that
because it's usually
that's
overcrowded.
yes, they are, because the thing about the urgent care is like a lot of times the healthcare provider is the person that works at the urgent care, and you can go to the urgent care and that be your primary place that you
Right.
go to get primary care in addition to the urgent care. And so if you have that coupled with real urgent issues that are not urgent enough to go to the ER, that's where you see like the crowding. Going back to the front desk staff, I think I shared with you all my experience. I was in there. I had it was that, well, I forget what the name of it was one of those slushes from Sonic. You know how you can mix up everything in there. And so I thought I was having an allergic reaction. But trying to get through the kiosk, they didn't have a person that sat out front. And I was like, oh my goodness. I know these people see me out here struggling with this thing. At that time, I think it might have been two other people in the waiting area, and they were, over under their blanket or whatever. They wasn't worried about what I was doing. And so it was a code thing that was supposed to be being sent to my phone, but I never got, I don't know. But anywho, but front desk staff, I do agree with that we would need to have more people there, because sometimes even though they have this, electronic things, this electronic way, so you still need that human touch, because sometimes there are people that might not know what to do, and there's a thing called malfunctioning. The equipment that we use might malfunction. Okay, great, great, great. All right, so one more person, then we'll go on to our and then I want you to be thinking about, as you're hearing people tell their top three and talk us through their top one, just think about when we talked about finances. Wonder how is these things paid for. So when it comes to urgent care, think about the different structures. Is there front desk staff? Is there a healthcare provider there? If they are they there the long term? What is their structure? Do they have CNOs? What is the structure? Okay, someone else volunteer.
I'll go next.
And that is who? Say your name again so I can see the name.
Oh yeah.
Okay, it's Carter. Gotcha. All right.
So my top three would be a hospital, surgery center, and a long-term care. I would choose the surgery center because I do have experience working in one, and I like how it's predictable, it's structured. You typically, with the one I've worked at, you don't have to do overnight shifts. You get to see a lot of different procedures and you get to work with mainly stable patients. Like you don't really have unpredictability because they have to go through a lot of screening and tests before they can even be at that service center. Um, for the organizational structure, you typically see just like team leads, nurse manager, director of nursing, and then throughout there's just a bunch of surgeons, and then they may have like a provider that handles some kind of orders, but typically it's just the surgeon. And then I would think what could make it better would be just better communication and maybe some more cross training if it's possible or within the scope of practice. I do know when I was at the surgery center, there would be some miscommunication on like if the anesthesiologist was still there and if we needed to like give Narcan because they gave them too much pain medication or something. So that's basically it.
Okay. All right. Thank you all for sharing. So yes. So you're at that point now where you for real need to be thinking about, okay, hey, is this the place I want it? Because you're gonna spend just as much time in that setting as you do with your family. It's like your second family. So you do want to consider your preferences, your personal preferences and all of that so that you can get in the best fit setting for you. Doesn't mean that your mind's probably gonna change. It might, but it's okay. But at least you're thinking about it in the real, like um, patient staff ratio. Are the patients more than likely going to be stable or it's going to be unpredictable? So all those things. Great, great, great. And the reason I want to try to talk about the structure part, not only because it's part of our lesson, our required readings, but also because once you go to these settings, for the most part, at some point along our journey, we do want to expand our career path. So in that setting, is there expansion? So those, for example, right now we're LPNs, but in those settings, is there an RN? Is there room for RN? Is there room for LPN to work on, um, the QA committee, or is there room for the LPN to work with MDS? So think about your career path. So that's why I was asking that question. Not only as part of our required reading, but so that you can be thinking about, is it career growth if that's what I want in this setting that I'll eventually choose. All right, so let's go back to we're gonna get the rest of you all doing pretty good. And so we're gonna go to our content here. All right. So we should be remembering some of these things. So some we're just gonna just read through, but um that would be the minimum. So as I mentioned, we're life learners. We're all the time trying to think of, hey, is this the best way to do this? What does the evidence show? And we're gonna talk about more about evidence later on too. So because we're not just haphazardly pulling things out of the air, the evidence has said, hey, it's at a minimum we should be turning and repositioning people that has problems with mobility at a minimum every 2 hours. The evidence has shown, that we can administer Tylenol alternating with ibuprofen if that fever is hard to break. The evidence. So these are the things. The evidence guides what we do. And so, with that being said, we are all the time attending trainings. We may be the one that's giving the training. And, at a minimum, we have that yearly evaluation. They ask us to set goals. And with those goals, how are we going to achieve those goals? Most of the time, we're signing up for some type of education or re-education, even if it's about learning a new skill or retraining with the skill that you already know. But nevertheless, we are continuing education. So as a student nurse transitions to the role of the nurse, there will be a need for autonomy. So you'll be the person, you won't be the mentor, you won't be with the mentor per se, like you're in class now. Of course, you will be assigned to someone. Some facilities now, some facilities say, hey, you got those licenses, let's go. We run you through orientation. And after that time frame is up, you're it. But you will need to know, hey, yes, while this is my team of patients, I have a strong foundational knowledge of how to provide the best care for them. In the event that I need to seek some verification, I'm going to reach out to my colleagues. but it's going to be on you. And then eventually, once you've been there for a while and you got your footing and you're comfortable with it, in the event that they need a mentor for new employees, they might ask you to be that person, to be that mentor. So it's just an ongoing process. So we talked about professionalism on last week, and we shared out on that. So professionalism involves being respectful, reliable, ethical, and accountable. If I'm running late, I can't do anything about running late, but what I can do is to call ahead and let the people that are relying on me coming in, being on time, to say, hey, I got have a flat tire, whatever it is, overslept, I'm going to be a few minutes late. In the event that you need to call off, don't just be a no call, no show. Make that phone call or whatever that communication is. Submit the email, whatever that facility's way of communicating. Make sure that we do that. Don't let it be that we are not being reliable. Because if you think about it as a way of just being disrespectful to the patients and then your coworkers, and so while being respectful and reliable, that builds trust within that team. Hey, because we said plenty of times, well, for example, Nurse Lisa not here yet. Something must be wrong because if she's not coming or something has come up, she will call. So because we have that cohesiveness, you kind of know your coworkers. And then in the event that something happens, like Lisa might have hadn't shown up yet, someone starts reaching out to you, hey, is everything okay? And then, hopefully everything is okay, but you never know. Sometimes something may have come up and they might be in danger or whatever. But because we have that communication and we kind of know the patterns, we've been respectful of each other and we're reliable. If we're going to call in, we call in rather than be a no call, no show. We kind of, create that camaraderie. And then in the event that something isn't going as normal, we know to look out or to do some research. Like I said, make that phone call to make sure that that person's okay. Addressing issues respectfully. You're not going to agree with everybody on the healthcare team, but in the event that we don't, it's a way to disagree respectfully. And we can call a meeting. A lot of times they're having meetings anyways with the families and the patients. That's just an ongoing thing. We may have to ask for a special meeting to be called, especially if what a family member is doing is infringing upon the patient's right, if it's infringing upon the worker's rights. And so all of that, we still wanted to address that respectfully because we do want to maintain dignity, privacy, and we don't want to damage our trust with our patients. We talked about the personal development plan. It is a continuous, intentional. It continues, even though you have that yearly evaluation where they ask you what your goals are for next year. Did you achieve your goals this year? Is this a continuous process? We are signing up to be life learners. It is intentional. So in some facilities, you can they promote getting certifications, and we have a slide here on that too. So you can work toward, but when you do the certification, sometimes there are certain number of hours you have to actually acquire doing whatever that skill is. There might be a certain number of hours of educational hours that you may have to take. So we have to be intentional about that process. We may have to pick up some shifts that we don't normally pick up because doing this shift, for example, day shift or evening shift, this is when this procedure is done. And so how am I going to get my hours on my record that say I've been exposed or I had training, doing this particular skill? Well, my normal shift might be 7 to 3, it might be 11 to 7, but because it's skill that I'm trying to get the certification done on is second shift, I may have to pick up some second shifts and drop off my regular shift. So the nurse decides it is ongoing, self-directed learning, and it does enhances our skills throughout our career. It's just continuous. That word continuous. So the professional development plan shows proactive engagement in professional growth, thinking about those things that you want to achieve for that next year and that next year. It allows for setting specific measurable goals. You all know about that measurable. Is it realistic? Within that time frame. What are those things that you need to do to acquire or at least be for that goal to at least be attainable? This approach encourages self-reflection and continuous improvement. So you be your own checks and balances. Hey, I really want this certification, but I'm not picking up any of those shifts, because on second shift is when it occurs. Am I still wanting this certification or do I need to change my goal? or do I need to pick up those shifts because I really do want this certification? And as a requirement of it, I must be exposed to a certain amount of hours, a certain amount of education. Okay. So there are programs for the new nurse or the novice nurse, as they call it, or new nurse. There will be preceptors, coaches, in different settings, they call them different things. And didactic presentations help new graduates develop confidence and autonomous with their decision making because it's on the new nurse, it's on that nurse. They have a license, is on them. But then at the same time, we don't want to just throw the new nurse out to the wolves, so to speak. And so we do want to have things in place. That setting that you work in, is there a preceptor or coach or something like that in that setting? If not, that might be a conversation that you can have. You might end up being the one that writes the program and lead it, oversee it. You just never know because you would think all the settings have all of these tools so that we can provide that best care, but some of them don't. Okay. So this life learning, regular unit-based in-service training. So if on second floor med-surg, we get a new piece of equipment and it's only used on that floor, OB, PEDS, then we will have that unit-based training there. In addition to that, sometimes there is just an ongoing monthly, just a routine meeting that they have because there are certain concepts they must review every year. I could think in a long-term care setting, I can remember walking into one of the facilities on their board there, they have it listed out for the year. In June, they do abuse. And I'm just calling out dates and times. In December, they do patients' rights. So it's an ongoing training that's, rolling every month, but then they may have some specific training that comes up as the our time going off as we get new systems. I can remember getting those new electronic systems here 2 years ago now, and everybody had to be trained, and so that was that specific training. But it's just a continuous thing. It's all the time something. So consider the best care being provided, the best job, the best healthcare team. What are those factors that would promote that best job, the best setting? We've talked about that already. So shared governance. Think about the word. What does share mean? It improves quality of care because we're on that healthcare team. We are thinking it through. We're being proactive, even though sometimes things might come up. We are communicating with the physical therapist, the healthcare provider, the primary doctor, the foot doctor, whomever. And as a result of that, because everybody's communicating, we're being proactive, things probably going to still happen. But because we're thinking about it and we're communicating, being respectful, we're being reliable, we work through whatever comes up. That says, I can come back here another day and get this job done and take care of these patients. And it promotes greater engagement and control over the whole nursing practice. So shared governance is viewed as an essential component of professional practice and is crucial for improving future healthcare systems. So shared governance, we're the little captain of the ship, so to speak. But nevertheless, we still need everybody else that are captains of their ships to also communicate with us and steer and get their boat back to land as well. So I don't know if that's a good example, but you know what I'm trying to say. So specialty certification validates expertise in a particular area of nursing. You can get a certification pretty much in anything now. Now, the National League of Nursing has that whole list, but then facilities, different healthcare settings, they have certification that you can hold within that facility also that might not be on the National League of Nursing's website. The certification demonstrates a commitment to maintaining high standards of practice. Certification often requires even more education, but it's promoting that continuous learning. So in order to, even though you take another test for the certification, in order to maintain that certification, you have to have so many practice hours. The nurse will also have to have so many educational units just to keep that certification. Enhanced knowledge can lead to improved patient outcomes. So all of this, what it's going to lead to providing that best care for your patients. And then overall, you're going to be satisfied. You're going to find satisfaction in it's gonna be like, well, I am making a difference because I am doing the most that I can do in this setting. Okay. So we're talking about shared governance again. Successful implementation. What are we doing? It with the shared governance model, it requires a foundation of collaborative counsel at unit, departmental, and organization levels. What that means is more than just us. It's more than just a nurse. Clearly define roles and responsibilities. Hey, if the physical therapist is supposed to come and do the therapy in the patient's room, that means that, we shouldn't have to go get the physical therapist. That physical therapy knows that they're supposed to come to the patient's room on Monday, Wednesday, and Friday for 15 minutes or whatever the order is. And so, what is my role? What are my responsibilities? What am I supposed to do so this client can get the best care? So being open and transparent, and that's on both ends. So we want to explain and tell our part and share our new ideas. So be open to the next person on the healthcare team doing the same thing. So it's going to require regular meetings. You may have to come in, stay over late. And a lot of times what they try to do is for that regular unit-based meetings, they try to have them either at the beginning or the end of the shift, and they have them more than one day. So hopefully it'll catch you while you're, on shift or getting ready to go. So you don't have to make a special trip to your place of work. But sometimes if you're off and it's something that comes up. So for example, something that comes to mind is in the event that something happened, like, one of those sentinel events, like someone loses an eye, life, or limb or something, they have to re-educate. That's just part of their policy and procedure. So it may be a called meeting, but nevertheless, we still it's going to be communicated to you. And then it's the expectation is that you come or get whatever training that it is, whether or not it's via electronic or in person. So continuous education and leadership development for nurses support effective participation in the activities. So, in contrast, a top down management style is not shared governance. So, even though we have our chain of command, the shared governance is we're all, equals. It's because it's going to take all of us working together to provide the best care for our clients. So, it's not like, if you're not the CNO, that your opinion doesn't matter, that what you do don't matter. Okay, so decentralized management and shared governance, the traditional hierarchical management style shifts to one where managers facilitate rather than control. So that shared governance, we're sharing whatever it is. We're not just, standing up there with a big stick or a big pen, so to speak. And so we're sharing whatever it is that needs to be done for that patient. Okay, so let's think about empowerment. So on your paper, just jot note. What do you define empowerment to be? What is that when we're talking about empowerment? And then as you jot note, be thinking about that your top setting that you listed 3 settings, that your number one, what would empowerment look like in that setting? So I'm gonna give you a minute and then we'll just hear from a few of you all. Empowerment. And then what would it look like in that setting, in your work setting? All right, so let me hear from two. What is empowerment? What's your definition of it? Let me turn our little timer off. And then tell me what would it look like in that setting that you chose. Empowerment. Volunteers.
I'll go ahead and go.
Okay.
Um, Empowerment to me is like working effectively as a team and having good communication with the different settings. And my three settings would be a nursing home, family practice, and an urgent care. But my number one would be family practice because that's what I've been doing for a lot of years. Um, the reason why I love family practice is because you see a variety of people. You see from newborn to 102 years olds, and you see different conditions, and you see different um, disorders because we have patients that have ADHD that are on the spectrum. We even have mental health patients like schizophrenic and bipolar and all of that. So we see a variety of everything. So you never know what each day brings. Um, the organizational part of it, we have a manager of our entire office. We have front office staff. We have the medical staff, which ranges from CMAs to LPNs, and then we have an LPN manager for the clinical staff. And then we have a plethora of providers from MDs to DOs to PAs to CNPs. Um, the way it could be better is better communication and better staffing at times.
Okay, great. So I heard you say there was a LPN. Was it, what did you call it? It was a different term that you used about the LPN. Is a manager? Is that what you said?
She's an LPN supervisor,
LPN supervisor.
and she manages all the clinical staff.
Okay. All right. Great. Great. Okay. One more person. Tell me about empowerment, and then tell us about your what it looks like in your number one setting. Talk us through that.
I'll go.
Okay.
I think empowerment would be, as far as in the work setting, for especially for the medical field, would be like being able to advocate for patients. Um, Especially if you see something or know something that's a difference, and you could just tell like they either really have no clue or idea what's really going on, or you could tell like they want to say something and speak up as far as like a provider or anything, and they can't for themselves, especially for children. I mean, just people in general, but especially with children and their parents, some parents can't advocate, they don't know how to, or feel like they can't speak up. So I feel like that is that's a big empowerment move. I do a lot now as general, just when you learn stuff as you go, or if you do stuff with your own children and stuff like that, you're able to do that. I would say three settings would be, I don't know, I guess a nursing home, um, anything with children, and anything with the elders, really. I mean, I said nursing home, but they're not always in nursing home. They could be just admitted into the hospital or emergency room and things like that. Um, I definitely think that some things that could be changed would be like communication. And as far as like providers are trying to more so not work with you, but you're trying to treat you as you're working for them instead of working as a team. I feel like that can definitely be changed. Or just like communication in general, as far as people being rude and snappy, and instead of just trying to do what's best for everybody on the floor. Um, that could definitely be changed. So, what was the other part of the question? Did I miss something?
No, that was it. Thank you all.
Okay.
Empowerment. This model creates an environment that enhances job satisfaction, increases professionalism, and improves accountability among the nursing staff. And all those things that you all just named, the staff work, the nurse working with the healthcare provider, all those examples that you gave, making sure we have enough supplies, so that we can do what we need to do for the patients. Great. Okay, so collaborative relationships. Shared governance encourages nurses to work together and collectively developing those partnerships. We don't have to, go home with each other. We don't have to go out to eat or anything like that. But while we're at work, we need to be partners working together, trying to provide this best care that we can for our patients, identifying, bad practices, best practices, on both ends. We want to do that so that we can be safe ourselves and provide, and our patients can be safe also. Shared decision making. This is the cornerstone of shared governance, allowing nurses to actively participate in policy and practice decisions. And so some facilities, they have all facilities have their policies and procedures. Some don't change or revise and or just review the policies unless something goes on, something happens and is related to that policy. But there are so many facilities where they look at all the policies on a rolling basis. And so you might could be on that policy review team. That means that what you're doing isn't working, but that policy needs to be reviewed, and you just stamp it on there. Well, hey, we looked at the policy on August 2026. No changes noted. Okay, so we have 3 patients. Okay, so remember we're getting to how we're paying for the healthcare that we are receiving. So let me just do some prior knowledge here. So patient A, and I, just be making this up as we go along. This patient is in between jobs. So more than likely, I don't know, but I guess I could have added this patient does not have insurance in between jobs. So that means, they probably don't have an income. That income might be low. More than likely, probably is low. Patient B has a child that has asthma. It needs routine care. The parent or guardian does not have insurance. They have a job, but it costs too much. Okay. And then patient C has Medicare and needs, hold on, let me stop sharing. I made this font too big because I did add something to that one. Let me make this font a little bit smaller. Let's see here. I didn't realize I was running off my little slide here. Let's go. I think I said this patient C needed, upper GI series, and that they needed an ambulance for transportation. So they could not get there to the clinic or to the hospital or to the place where the procedure would actually be done at in a private vehicle. They would need to get there via an ambulance. So just think about it. We're talking about how we're paying for the services. We're gonna check ourselves, but right now, just jot note. Patient A, how do you think they're gonna pay for the services that they're gonna need? More than likely, what are they gonna be subscribing to that's gonna help pay for those healthcare needs? Patient B is the child. How do you think this parent, or what resources out there that this patient, the parent can subscribe to, and that this child can receive the healthcare that they need? And then patient C, we told you the source is Medicare, but then which parts pays for the upper GI, which parts pays for the ambulance transportation? So we'll come back to this. So I just want you to be thinking, these are some scenarios. We provide all this care in all these different settings. How is it paid for? What if they don't have insurance? What if their income is low, none to low? How do we not take care of the patients? No, we still provide the care, but more than likely there's a resource out there that they can subscribe to or is available for them so that their services can be paid for. All right, so we have official government healthcare agencies. We have, they're supported by tax money. So like, how are these agencies paid for? The primary service, if we can prevent something from happening, prevent a disease, prevent an injury, that's where we want to be, that primary level of care. And so there are mandated programs and non-mandated programs out there. But prevention, disease prevention, and health promotion is what we want to hopefully stay at. But, we know sometimes that's not the case. We have to provide that tertiary care. And so just think about those different settings that would provide that health prevention information. And so I can think of like the Department of Public Health. They have so many programs that they implement, and they need nurses to do it. Something I can think of is the Well Woman, and they may be called something else in your state, but it's a program that, like they have a screening list for women and they have a screening list for males. So all the different things that we should be having done as a male or female, that program actually kind of holds that woman's hand and walks her through, hey, you have to have a mammogram. And it's an additional resource and support, in addition to their healthcare provider. Another one I can think of is where the dietitian they actually have nutrition classes. In addition to that, they have live cooking demonstrations. So you can make and take. Not only do they give the information about the carbohydrate, about the sugar, the carb counts and all of that, but they actually have recipes, and those recipes, they make them, so people can actually taste them, because a lot of times it's like, well, hey, I would try that, but food is so expensive and I don't want to take my chances with making that, and it doesn't taste well and I don't like it. So I've spent my money on this. I know how this tastes, so I'll just go with that. But the health departments, they have I don't know if you all have rotated through those things, departments like that in your area, or something like the health department. Just check it out and see what do they actually have. They actually have all kinds of programs. I'll tell you about one more, then we'll move on. Where people with arthritis, they have this exercise program, and a nurse leads that. They come in, they do it virtually and in person. And so it's made available for the people that have arthritis, because, if your joints and things hurt, you tend not to move, not to be as mobile. So it's a program that's implemented, and that's tertiary, because the person has arthritis, different kinds. And so they're trying to help that person maintain as much mobility as they can. Now, you will see some programs offered in some states and some not offered in others, because remember, there was that opening where the state could decide on their own whether or not they wanted to receive those funds from the federal government. And so when states governments decided, hey, I don't want those funds, what did that mean for those programs? They don't offer them in the area, because more than likely the state doesn't have the money to pay for it. And so the states that did, welcome the money, they're able to implement those programs. So that's why you'll hear it vary by state to state. So again, just focusing on disease prevention and promotion and wellness. So focus on disease prevention and wellness, and are appropriate for PNs interested in community-based services. Like all those different programs I just called out, there's an opportunity for us to work there as a PN. And there are many, many more. All right, so then we have OSHA. OSHA prevent workplace illnesses and injuries. CMS, we have Medicare and Medicaid. They are moving toward value-based. They're looking at the value of the care that we're providing and how they're determining the value. They're looking at the number of rehospitalizations. They're looking at the number of medication errors, urinary tract infections, pneumonia, and things like that. So the Centers for Disease Control, they're collecting data. And their whole thing is to do that surveillance so that we can prevent diseases if we can, or lessen the number of people that's affected. And then we have the US, the FDA. So foods, medications, and also medical devices. Are they safe for us to use and or consume? The stent that's in someone's heart. The FDA has said, hey, this stent is okay for the doctors to actually implant in the person's heart, or it's not. There are a bunch of people out there, companies out there, whose products that were not approved by the FDA. And then also you have products that are approved, but if the documentation shows that this product is harming someone, they pull it off the market, they recall them. Okay. So again, we said value-based. They're value-based. And the examples that I gave, the hospital readmissions, they look at these performance measures, infection control. How many people are being treated for an infection, the hospital-acquired infection? They actually go through the documentation. They look at the nurse's notes, they look at the medications, they look at all of the different tests that were run. And so, did this client, were they complaining of this? Is it more than likely this patient had this infection when they came in, or was it caused, or did the staff cause it? So they look at that value, need to know. So private healthcare agencies, services, of course, you got to pay for the services. How are they being paid for? Some depends on if it's a skill, the insurance pays for it. If not, sometimes people pay for it out of their own pocket. Then they also have like these other, they're not insurances, but other resources payer sources that helps with that. So private insurance costs are passed on by the employers to the consumers through pricing of goods and services, meaning everyone is indirectly paying for their healthcare costs. It's not free really to anybody, even though it may not cost as much. And then the direct cost might not be to that person, but some type of way it is being indirectly paid for by someone. Okay. So most private plans require members to pay a deductible, the co-insurance, co-pays. It requires all of these out-of-pocket, costs. And it's sort of like the what's the thing that people sisters subscribe to, the Netflix. You know, if you don't pay for the Netflix, the monthly subscription, and you can't click on a thing, you can click on it, but it won't show anything. And so you pay the monthly subscription, but if you want to see something extra, like the latest movie that just came out, you got to pay another fee. So co-pays, co-insurance, premiums, and all of those different things. So home health care, it takes place, in the patient's home. It is directed by that registered nurse. So we work under the supervision of the registered nurse. And even home health, you all, it's home health. I think I'm going to tell you the wrong thing. I was thinking about hospice. Hospice can occur in someone's home or in the long-term care facility. So home health occurs in a person's home. They must have that skill in order for the insurances to pay for it. And we have a slide here on hospice coming up pretty quickly here. So skilled nursing, what is that? Medically necessary care to improve health or maintain or slow decompensation. So think about a person after surgery. They're needing to, we're just say a hip replace. So they're needing to get that hip back in motion so they can walk, learn to walk again. And if they are able, able to walk, are they able to walk how they were prior to the surgery to their best, their optimal level of care? Does this patient need IV medications? Do they need wound care? And the list just goes on and on about skilled care, but it does pay for it if there's a skill. So it's so important to be documenting those skills that you're providing. So hospice can be provided in the patient's home, and or it can be provided in a long-term care facility. Even some hospitals have hospice units, and so it's inpatient hospice care. But nevertheless, they're saying that this person is deemed terminal, and the goal is to maintain comfort if someone is listed as hospice. So you will not see like routine, for example, if you go to the doctor or the doctor's coming in, they order, just have your routine CMP done or CBC done. If a person is under hospice care, certain procedures are not routinely done. Something as such as getting just regular routine lab work, because hospice care, that person is deemed terminal, so it's not needed. Now, can a person unsubscribe to hospice and get physical therapy? Yes, but as long as they're on hospice, they cannot receive, therapies like that. So they can unsubscribe for however amount of time and then resubscribe. Usually people go on and off, but it is saying that this person is terminal. Like I said, I've seen people get better and they drop the hospice care. And with hospice, it's a holistic approach. They think about the person's spirituality, mental health, physical health, and everything. So palliative, the person can receive this care at any stage in the disease process, unlike hospice is terminal. And so life-saving measures can be chosen. If someone's getting palliative care, they may still get routine labs done, x-rays and things like that. So I don't think, okay, I've heard someone say long-term care facility. I haven't heard anyone say assisted living, but just to throw some others out there, adult daycare, wellness centers, residential care. These are all places that we can work in, because these are places that patients can, and they may not call them patients, participants, residents, that they can receive the skilled care that we can provide. Okay. So community health services, this is just looking at providing that education. These are we wear so many hats. And even within the school nurse, sometimes you're called on to be the advocate. So what they'll do is they'll have you doing the in-services, doing a PTA or PTO meeting. and or you might be the nurse that's trained to the CPR trainer. And so you may have to train the coaches, in all of those that are on the different athletic teams, the cheer teams. You have to train all of those staff, you know, to be certified in CPR. So you can be that CPR instructor. So just because we say school nurse, of course our patients are going to be the children, right? But still, there are other opportunities in these different settings. That's why I was asking about the structure. Have you really stepped back and looked and saw what was really going on inside of the different settings that you desire to work in? So we have Medicare. Generally, we take care of our elderly. So 65 and older, you consider elderly if you're 65 and older. Now, there are some disease processes. So coverage is also given to certain younger persons with disabilities and persons with end-stage renal disease. And there are some more disease processes. There are more that the person does not have to be 65 to receive Medicare, but traditionally it's for that person that's 65 and older. Okay. So be thinking about, remember those three patients that was it three patients, three or four? So be thinking about as we go over these next couple slides and look and see what did you write down for your person. Okay. So Medicare, that one patient had Medicare. Think about what they needed. We have four parts. We have A, B, C, and D. So D is for drugs or medications. Okay. And then A, and then B. A is in the hospital. So all those things that this patient is going to get while they're inpatient, while they're actually admitted inside the long-term care facility, inside the hospital. So Medicare is traditionally those things that the patient and services the patient would need when they are discharged. So just think about those different resources. And then C is offered by a private company that connects with Medicare, and it also can prescribe pay for some of your medications. It's kind of like that Medigap C does. It kind of stands in the gap, but it's an additional part of Medicare that the person has to subscribe to. It's a private actual company. Okay, Medicare is usually primarily for those that are over 65. Again, value-based program uses selected clinical processes of care measures to assess hospital quality and determine reimbursement. I'm gonna tell you this example, and then we're gonna take our first break. Patient comes in for pneumonia. Patient ends up falling and has a broken hip or broken arm. And so we're going to take care of that patient. But that value-based system, what it does is, this patient came in for pneumonia. They have a broken arm. They failed. That's unrelated to why they came in. And so they will determine reimbursement, whether or not they will pay. Now they're not gonna tell the hospital not to take care of the patient, but when the hospital send in the bill, they might not reimburse that hospital because they will look at the record and say, well, hey, what does falling have to do with pneumonia? What does falling and breaking an arm has to do with pneumonia? So that's that value-based system. All right, so we're gonna pause right here and we're going to take a 5-minute break. We're going to push through our information and we're going to leave the bulk of our time towards the end. Let's see, what time is it? It is 9:02 in your area, so return at 9:07. Remember, this video still plays, you all, so make sure your cameras are off and you're on mute. See you at 9:07. Oh, sure. If you all would turn your cameras off, please. Miss Rogers? Miss Rogers, are you there? All right, let's come on back, you all. And so I might lose you because they just issued a warning. So, but nevertheless, we'll keep on going. So I would like to add anything that you need to log off or anything, if something's coming up and you need to step away from class, feel free, just send a message and just say that, something's come up and you need to log off. Because the expectation is that, you're at least listening and being engaged, during the class session. But we know things come up. So in the event you need to do that, just send a message to me. Okay, so we're talking about Medicare. So again, think back about those patients that we had up there. Just think about how they're going to pay for the services that they need. So Medigap is also a an insurance that's available, and it is, what the word said it is. It stands in the gap. So remember, the person has Medicare, it has all those different parts. And then they may subscribe to it. They may even have their private insurance. But then it depends on the disease process and what's really going on with them. It might be that they need some additional insurances to help offset those bills. If you ever looked at your hospital bill or your doctor's bill, those things can add up. Something as we think as a simple blood draw, x-ray, those things are they can be costly, right? So just gonna take just a minute to look back at your patients, those three patients, and just kind of look and see what would you list for them to help pay for their insurance. And then we're going to continue through the PowerPoint. Okay, they put us on for the patient that was it an upper GI and then they need the ambulance ride. What are y'all thinking? Which part of Medicare is going to pay for that for? Let's see what y'all put in the chat. We had A, B, C, and D. Which part? A was for what? Medicare Part A pays for what? Inpatient or outpatient? So, and just another, okay, inpatient, got it. Just another thing, you all, these sessions are recorded, and I know you all have backgrounds up, but if it appears that you're not there, that's going to count as an absence. I want you to make an informed decision. Again, if in the event that you need to step away, just send me an email about what's going on, and so, it's fine. All right, so Medicaid. I saw you all put in the chat, inpatient. I do agree with that. So Medicaid is income based, lower limited income. So a person can still have an income, but they can't subscribe to the insurance because insurance is expensive. Even some of the plans that your employer offer, sometimes it is costly. And so if you pay for the insurance, then the income is going to be less. But nevertheless, income for Medicaid. And so if there's a scenario and they mention the person's income is low or limited or none, Medicaid. We still have to take care of the patient, but Medicaid is how those services are actually paid for. Now, as I mentioned earlier, Medicaid and a bunch of other services are going to vary from state to state, just depending on if the state received those funds or not. Okay. Now, a person can be on Medicare and Medicaid, just depends on if they're under 65, but they have that end stage renal disease, so they still qualify for Medicare, but then their income is low, so they can have both. Okay. The ACA initially intended to mandate Medicaid expansion, but because of that ruling in 2012, it said, hey, states can decide whether or not they want to receive that additional funding. It essentially was up to the governors. And what that meant is those services would vary from state to state. One state may offer this, a state might not offer it. So again, what we just said, Medicare is a federal program primarily for those age 65 and older. It does cover certain disabilities. It offers hospital, inpatient, A, B, C, and D, medical care, optional personal prescription drug coverage. Medicaid is a joint federal and state program because the federal program, the federal government sends those funds to offer those different programs in the area. Medicare does not cover long-term custodial care. Remember, they have to have that skilled care. We just said each state administers its own Medicaid program with minimum federal income guidelines. Specific states, they pretty much do what they want with that. So again, think back about those patients. So we have CHIP, Children's Health Insurance Program. It falls under Medicaid. That's who pays for it. It is free or low cost health insurance. It doesn't mean that the babies get any less care than the next baby. It's just saying who's paying for that insurance. Think back about your patients and see what this insurance cover. Again, you all, it's a storm in my area. I may have to end up logging up, but I'll push on until I can't go anymore, till it's unsafe. CHIP specifically targets children and families with incomes too high for Medicaid, but then it's too low for that private coverage. So again, insurance costs a lot. And so a person may have a job, but then it's such that hold on 1 minute, you all. Trying to get it back on the screen here. But then to subscribe, pay that monthly fee, that premium, those co-pays, is just too much on that parent or guardian. And so they might not have insurance, but then you have chip out there. And in some states, it might be called something else, but essentially that child still gets that, insurance coverage. So that means they can still go to their get their preventative care, their immunizations, their well child checks, and so forth. It does not change the kind of health care that they actually get. Is expected. They still get those same services. National Quality Forum, a not-for-profit membership-based organization, and it's focused on quality. What does quality? We keep saying quality, value-based. I gave you some examples. Think about what that looks like with the skills that we have to perform. Okay. National Quality Forum, instrumental in advancing efforts to improve quality through performance, measurement, and public reporting. So what that means is these facilities, what they do is they're reporting the number of falls, the number of in-house wounds that they may have. They're reporting the number of that have infections, and with the infections, they have to list it out. Was it a wound infection? Was it, pneumonia? And so there goes that quality and value. They're putting they're stamping it with a certain value based on the number of falls this facility gets, and they give them a grade. I don't think it's A, B, C, D, or E, or F, but they grade them based on that reporting that they actually do. Private insurance costs are passed on by employers to consumers through pricing of goods and services, meaning everyone indirectly pays for some part of their health care. I told you that. So the uninsured, think about if I don't have insurance, am I going to the urgent care? Probably not, because what happens in that urgent care? You got to get that money or that insurance card and that copay. So more than likely, if I don't have insurance, where am I going to seek treatment at? Where am I going to go? More than likely that hospital setting, because they don't turn you away. And then more than likely, where am I going to be at in the disease phase? For example, if I have the flu, if I have, pneumonia, and I'm stopping because, like I said, it's storming, and thunder didn't hurt us, but lightning does. So I'm kind of pausing because of that. So a person that doesn't have insurance, more than likely, they're going to seek treatment late in that disease process because they're going to put it off, from actually going. And so, healthcare reform, the Affordable Care Act. Let me just pause right here. I'm going to send Dr. Tenza an email so she will know what's going on, because I'm most likely going to probably have to log off here in just a moment because I think it's going to probably be kind of unsafe. So let me just we're going to pause for station identification, you all. Just hold on. Let me send her this email. This doesn't count against your break, but you can just pause. Ooh, how many times now has it happened doing since we've been together? You all, it's happened several times, but can't do anything about the weather. But we're gonna press on until I have to jump off. Okay.
Excuse me.
Mm-hmm.
If you don't mind me asking, where do you stay where you have storms all the time?
And this is not usual. This is Alabama. It is when I say storm,
You Alabama? Man,
yes,
you got a lot going on down there.
it is. It is storming, honey. It really is. And it's usually not like this, but it's been so hot. Like our heat index today was like 115. The temperature is like 101. So the environment is just really volatile. So you can't do anything about that weather, but get somewhere and sit down. But I'm going to press on. So I want to get you ready for it. Your HESIs, your NCLEXs, and unit exams. Press on as long as it's safe. All right. And it seems like it's always on a Tuesday, you all. Wednesdays and Thursdays, it rarely happens. I don't know. But anywho, so healthcare reform, the Affordable Care Act, it was created so that people could afford the healthcare because insurance costs a lot of money. And so that's hence the marketplace. You go in and shop around and you pick what insurance that works best for you, because if a person has a certain disease process and they need a whole bunch of, several different MRI every month or every 6 months, traditional insurances only pays for so much of that. And so the marketplace the Affordable Care Act allowed for a person to go in and select what was best for them. And so it did not hinder or delay their treatment. The Affordable Care Act, before the Affordable Care Act, or Obamacare, as people say, you were penalized for having a pre-existing condition. And so the insurance companies would decide, hey, we won't pay for anything that's related to whatever that condition was that you had listed on your record, because they consider it as pre-existing. And that's what the policy says, that they didn't have to. So they didn't. They weren't going to tell you couldn't go get your health care, but they were not going to pay for it. So the Affordable Care Act opened it up so that those things a person would be penalized for having to try to take care of themselves. So managed care, you just have these different ways of paying for healthcare, managed care. So you have the PPOs and you have the HMOs. Nevertheless, the people still get the healthcare that they actually need. And so patients receive healthcare from a list of providers who participate in the PPO or the HMO services. Just ran into a young man. Well, I would say young man, but I'm sure he was probably about 60 something. But his daughter maybe not 60 something. But anyways, the story is the daughter transitioned from being 18 to 19. So whatever services healthcare provided, healthcare, whatever insurance she had at 18, it no longer covered her at 19. And the child has a chronic disease process. So it's like, hey, what do we do to get this baby covered so that we can still get these services that he or she's going to actually need. So it's a big to do when you're working. If you might decide to be on that financial team within that facility, and you can as a nurse, you're looking at the documentation, making sure doctors are documenting, nurses are documenting, because it's directly tied to that facility getting reimbursed for those services that they're actually providing. So think about this. If they don't have that financial team that's looking at all the services that they're actually providing, and it's documented, what happens? That facility doesn't get reimbursed. And over time, what's going to happen to that facility? It's going to close. And so never mind all the other policies and things that they have to, the red tape that they have to go through to just exist. In a hospital recently had to change their status, and they have like a new wording, so to speak, just changing their status. And so what that meant was they were able to stay open, because at the other status, it meant that they had to have all these different things. Did it mean that this hospital was not providing the best care for the community? No, it didn't mean that. It's just according to the policies that people are creating, they couldn't exist with that name. So they had to change their name. And so what that meant, they fell up on a different reimbursement status. So all of these things you all do matter, like how we paying for this healthcare. Organizations of healthcare providers that are accountable for quality, costs, and overall care of Medicare patients, is ACOs, must have defined processes for promoting that evidence-based care. Can't get away from quality, value, and evidence-based care. Medicare and Medicaid CHIP. Okay, so the goal is to improve outcomes. We have all of these different things going on. This person may subscribe to this insurance and it does this for them. This person may subscribe to this insurance and it doesn't do this for them. But the whole goal, whoever created these insurances and these ACOs and MCOs, is to improve outcomes. They say, hey, someone step back. And they looked at the evidence. They say, hey, we need to have it where, with CHIP, for example, that this child can still get their preventable services. They can still get the immunizations if the parents so choose. Because with this child more than likely going to have the better outcomes. Because if there's something going on, we can catch it at the preventable checks, at their well child check. Okay. So PPOs allow you to see out-of-network providers, but at a higher cost. So yeah, you can go see who you want to see out of our network, someone that's not on this list, but hey, just know that you're going to have to pay for it at your own pocket. And that's fine. The patient may choose to actually do that. But just know they just need to be informed that that's what's going to happen. Okay, we need to know QSIN, you all, quality and safety education for nurses. What is this? The overall goal is to prepare nursing students, equip them with all the tools that they need to provide that best care. So it's to prepare nursing students with knowledge, skills, and attitudes necessary to continuously improve the quality and safety in that system that they're actually working in. So nursing students to provide that best care, patient-centered, teamwork and collaboration, evidence-based practice, quality improvement, being safe, keeping us safe, the patient safe, and looking at the information, the informatics, looking at information and technology to communicate, manage, and knowledge to mitigate errors. Hopefully they don't have to happen. Hopefully this error just will not happen because, we have looked at the information. We understand the technology that we're actually using. We talked about shared governance early on, shared decision-making, the power to make practice decisions characterizes the autonomy. Remember, as that new nurse, you're going to have that autonomy. You're going to be working on your own and you're going to be making some decisions. And you will have, because you have that strong foundational knowledge, even if you need assistance, you're going to reach out to that colleague and say, hey, I need some help here. And that's okay. So official government agencies focus on disease prevention and wellness and are appropriate for nurses interested in community-based services. Remember all those different programs that I told you that the Department of Public Health actually offers for the community. Nurses pretty much run those programs. I told you about the registered dietitian runs that nutrition program, the live cooking classes and all of that. Who wouldn't want to do that? That's nursing at its best. And all of those things, you all, think about the things that it prevents. The Well Woman program that I told you about. Even though you go to the doctor and they say, hey, did you get your memo? I can write you the script so you can get it done. But if you have that program that kind of like holds your hand, reminds you more than once, you're more than likely, that patient is more than likely to actually, get those services that they actually need. So the future of nursing, I don't know if these things will ever happen. Scope of practices, I think we all need checks and balances just to guide us along the way. And it's like a tool that guides us. And so it gauges us so that so the public is protected. And how is the public protected? That Nurse State Practice Act tells us as nurses what we can and can do. So we have STEEP here. Need to know STEEP: safe, timely, effective, efficient, equitable, and patient-centered. So just think about the words like safe, avoiding injuries, keeping people away from harm, keeping harm away from the people. Timely, are we doing this in a timely manner? Or are we taking all day to do something that whole shift, something that should take place in 1 hour? So effective, provide services based on scientific knowledge to all who could benefit, and refrain from providing services to those that are not likely to benefit. If I don't need that service, I don't need that service. It would be just a waste. So efficient, avoiding the waste. Equitable, providing the same care, no matter my pay status, no matter my ethnicity. And then it is based on my preferences, that patient centered, my needs and values and the things that I, value. Okay, so this is the same thing again. Just a different I add a little picture here. Okay, then I think I have one more slide on. Yes. So in the STEEPS program, think about it. Think about teamwork. If we're thinking about keeping people from harm, or we're thinking about being timely, if we're thinking about waste so that we don't waste, that improves the team communication in healthcare. Because think about the patient. They're going to have better outcomes. They're going to tell you that they have better outcomes, and nevertheless, we're going to keep them safe, and they're going to be receiving the best care that they can. So this STEEPS aligns with the Agency for Healthcare Research and Quality. And then the mission is to improve healthcare quality and safety. That's the whole, we want to provide the best care. That's just another way of saying providing the best care possible. So let me ask you this question. In the chat, need everyone to put in the chat. Why is evidence necessary? We keep talking about providing evidence-based. Have your 5 references, the latest 5 years, evidence. Why is that necessary? So I'll give you a minute to type in the chat. Why is evidence necessary? Evidence-based care necessary. Just put it in the chat and then share it out so that everyone can actually see it. Why is the evidence necessary? Evidence-based care. What's it do for the patient? What does it do for their outcomes? Does it negatively affect their outcomes? Does it positively impact their outcomes? What does it do for that healthcare facility? This patient is providing the latest evidence-based care and they have positive outcomes. That facility is probably going to have good reviews. More people will come. If something happens, that patient is more likely to come back. And it just dominoes to great things. And look and see what you're putting in the chat. Good. Evidence, safer care, better outcomes. Okay. And then like someone put trustworthy. Yeah. So they're like, well, hey, these people are doing the best that they can. This is what it has been shown to do for, this is the better thing to do. And so that, like, okay, they really do have my best interest at heart. Even if something does come up, along the way, that's a hiccup or whatever, they still will have that trust that you did the right thing. for them, even though they may not have a good outcome. So how best evidence for practice guidelines is determined. There's usually a question. Pull up all these resources. What do the resources, what does the evidence say about the question? They even may pull in a panel of experts. You can be an expert nurse. And what you do is you look at the information. And then guidelines are determined. And then we use critical thinking skills. The gathered evidence is combined with the clinical experience, and the client's preferences and values are taken into place. All right, so we need to know this right here, you all. We have this plan. It starts with plan. Do, study, and act. So it's a continuous cycle. So in the event that we try something out, we plan for something, try it out, doesn't work, we just keep going. We just start all over again. We just keep going, redo the cycle. We can implement whatever the change should be or need to be, but we just keep going. So let me just read them out here. Plan, define the aim. Plan your data collection to answer the questions. Then we're going to actually do, implement, try it out, implement, to do. And then we analyze it, the data, and compare with our predictions. Did it work or did it not work? So, and then if it doesn't, like I said, it's just a continuous process. Just redo it all over again. You can add in new interventions or keep what you got and just try it one more time. But nevertheless, it's a continuous process. And then if you have to go backwards and forward in that plan, do, act, you can need to know. So types of evidence. Systemic review combines and evaluates results from multiple high quality studies. So what does the evidence show? And so based on that, that's how we come up with our policies, procedures, and our best practices. And so in a lot of facilities, you all, they have like these annual events or webinars, and you might be one of the presenters as the best practice of whatever it is that they're talking about inside that facility, a skill or something that they found out. Because a lot of facilities have, especially in the areas, have the same electronic systems that they're using. So if that facility says, hey, we found out how to best use this system and to increase our documentation as a result of it, when that nurse comes and reviews the bill that we submitted and they look at the documentation, we are getting 95% of our reimbursement. That's a big thing, because just because that hospital or that facility submits the bill doesn't mean that they're going to get that money back. And so though that leads to that evidence, the best practices. Okay, so research databases are used to find peer review. You all know about this in the last 5 years. Okay, so quantitative research versus qualitative. So quantitative is some type of two variables. One variable receive the group intervention and the other one does not. But quantitative is anything that has a value. Whether not qualitative, you gather information, and it is through, going too fast here. It is through information that you gather through an interview. The person may be given a questionnaire or survey to complete. That's qualitative, that's subjective information. But quantitative, go back to the words, you can see it. Quantity, this is measuring the height. Echocardiogram, the results of the echo, it shows how much that heart is beating. So that's a quantity. It can be a blood count, because there's a quantity of that blood count. So quantity and then qualitative. Now qualitative, we do like a lot of one-on-one in person. It could be via Zoom, and you're having interviews with people. You have a list of questions that we have looked at based on the peer review articles, and it says, hey, we need to ask this. So for example, we can do a focus group on a group of people that have diabetes and pain. What does the evidence say that we need to ask? What questions do we need to ask? And we ask those questions, we gain more information. From that information, we can submit articles, we can submit information to insurance companies, hopefully to impact change. In that example that I gave, a lot of the patients or participants said that they felt they could manage their diabetes better had they got their pain under control. So it's like, okay, what can we do about the pain? Does it need to be where a diabetic automatically sees, goes to pain management? Should that just be part of the person checks this off on their list that they have it? Well, that means they will automatically see a pain specialist. It might not be that they need to go all the time, but it might be because pain in diabetics, based on the literature, we found that that's a common thing. So that's just an example that I gave about the qualitative um, information. So finding solutions, then you ask the question, you search the literature, that will evaluate what you found. Can you implement it? Then you want to evaluate. That process doesn't change. The PICO, to put it in a different perspective, is the same thing. You define who or what the question is about, describe what you're going to do, and then see if there's an alternate. For example, self blood pressure management. So we ask patients to measure their blood pressure, write them down, keep a log, take the medication as prescribed. The alternate would be the person does not do self blood pressure measurements. They just take their medications, watch their diet, and when they go to the doctor, they get their blood pressure that way. And over time, what happened? Whose blood pressure was better controlled? That's just an example of how you can put your project into each one of those little parts of PICO. So randomized controlled trials are considered gold standard for determining cause and effect relationship. So the example that I just gave about whose blood pressure is better controlled. We randomized, we selected, this person, every other person was supposed to do self blood pressure measurements. The other one was not. And you all, when y'all hear me pausing, that's because I'm seeing lightning and stuff like it's getting better, but it's still rough. So core measures are used to track how often hospitals provide, listen to this, you all, provide recommended evidence-based care. Remember I said that even though the hospital and these agencies, urgent cares, they send the bill in, you have the nurse that comes and look at the evidence. What's the evidence? What was documented? They look at the care plans, they look at the documentation, the nurse's notes, the doctor's progress notes. They even look at the medications that prescribed. They look at the orders. What lab results did we get? What x-ray results did we get? And those are called core measures. They look at that and they say, well, this patient that came in found out they had pneumonia. Did the doctor order this test? Did they order this medicine? And essentially you kind of match it. You match their record with all the core measures that says that a person that's being treated for a heart attack have all these things done. Person that comes in that says it has chest pain. Did we move them back in a timely manner? Did we do an EKG in a timely manner? Was the EKG done at all? So core measures are used to track how often hospitals provide the recommended evidence-based care. They will help ensure that patients receive high quality standardized care based on the best available evidence. So if something eventually, happens, well, we're going by what the evidence shows that we should have been doing. Or our documentation says that we were not doing what we should have been doing. So you have this cumulative index to nursing. I think this link is also inside of your your Canvas. You all do know that there's a whole library at your fingertips, right, in your Canvas. Do y'all know that? You can actually go to several different libraries and all these resources that houses articles and everything. It's up in your I think on mine is at the top, but it's like above where the weeks start. It's part of your resources. You can go to any library inside of your Canvas, and you all probably already do that. Ooh, yeah, wow. It's storming for real. If you thought I was joking, I know you heard that. That was thunder though. Okay, so health policy, we're gonna push on, y'all, push on. Health policy relates to a health concern or issue and are meant to address public policy goals. Policies result from a public decision-making process that directs the action or inaction of governments. Decisions are made by authorized government institutions such as legislators or courts by the government authorized entities. Health policies address public policy goals. So the Board of Nursing oversees nursing licensure and practice standards at the state level. Again, now usually for LPNs and RNs to work to be part of the state board, that there are some paid positions, but don't think that you can't be a part of their board. But usually it's volunteer. But nevertheless, they oversee and they're like the checks and balances of the different facilities and everything. So that might be something that you're interested in, working on your board of nursing. Health policies, you have the PDSA, Patient Self-Determination Act. It requires healthcare facilities such as hospitals and nursing homes to provide patients with information related to their preferences for end-of-life care. And so you notice every time you go in, they say, have you executed, you have a living will? Do you want information on that? The Emergency Medical Treatment and Labor Act, it acted to prevent denial of emergency services to patients because they didn't have the insurance or they could not pay. So that ended that. Gotta see them, provide the best care. Why not? Are you all able to hear that? I know you can't see the lightning flashing, but let me just stop for a moment. Let me just pause. Are you all hearing the storm? Okay. If I lose you, just, I don't know, probably don't log back in because it means that it's over on this side. We're gonna press on. We don't have long. Okay, so we need to know about OBRA, you all. OBRA, all this stuff we need to know about. So when I say need to know, you still need to know it just for NCLEX, HESI, and also the exam, just so that you have a good foundational knowledge. So what is this OBRA, Omnibus Budget Reconciliation Act? What does it do? It introduced measures to control healthcare spending. And I know you all probably have heard that the United States has the most expensive healthcare that it is. And they have looked at like our outcomes compared to other places. Like, why does it cost so much? Because the outcomes, are not so much better. So this act significantly reformed long-term care by requiring, listen to this, you all, comprehensive resident assessments. So as an LPN, we can work on the MDS team within long-term care. So most people just think of the nursing home, you have your team of patients, but you can actually be on the MDS team. And they may call them something else, but they have to submit a minimum data set. And it is a comprehensive assessment. They look at specific things. Like you will go in and you'll ask, like they want to see what your patient's understanding is. So you go in and tell them, you give them 3 words. I'm going to give you these 3 words and I want you to repeat them back to me in this order. And then you'll look back in their chart to see if they had any falls, to see if they had any infections. How many people does it take to feed this person? How many people it takes to bathe this person? It's comprehensive, it's detailed. And so the OBRA of 1987, it says, hey, we need to do this comprehensive assessment. It also mandated increased staffing training and quality assurance processes. So you have a QA team also, you all, in the hospital and also long-term care facility. So you do your onboarding, ask about these other, positions and teams that they may have within those facilities. Okay. And so it does encourage that interdisciplinary collaboration. Say, hey, we need to be talking to the dietitian and physical therapist, which we've been talking about all along. It encourages that interdisciplinary collaboration. We talked about the FDA, foods, drugs, and also medical devices. Are they safe for us to use? If not, they do not approve them. And just because they've been approved does not mean that they won't pull something from the shelf in the event that it shows that it's not safe for consumers, for us to use, for us to have inside of our body, for foods for us to consume. So we know HIPAA, protect the privacy. Joint Commission sets these standards, and they usually come into your hospitals. Most of the time when Joint Commission comes in and we have clinicals, they send us away as nursing students. But nevertheless, they come in and it's just a regulatory, it's a checks and balances thing. It's just to make sure that we're providing the best care we can. Not only that, but also the care that's set by the rules and the standards. Because they want the best for our patients, the best for the community members. So they come in, they say, "Hey, let me see what you're doing in here, nurses. Let me see what you're doing in here, physical therapists." I think it's actually healing, y'all. It's storming. Let's move on. I'm still with you. So, Anderson policy making model, and it's similar to the API. You look at it, we come up, gather some information, we decide what we're gonna do. We make a decision. Yes, we're gonna do it. We'll actually do it. Then we evaluate it. And see did it do any good? So Anderson's model for policy creation follows a sequential process. I'm gonna read through this. It begins with agenda setting. We need to know where issues are identified and brought to the public attention. Okay. So assessing, we gather all this information. This is followed by policy formation, where potential solutions are developed. The third stage is policy adoption, where a specific course of action is chosen. Next comes policy implementation, where the chosen policy is put into practice. Finally, policy evaluation occurs to assess the effectiveness of the implemented policy. Understanding this sequence is crucial for nurses to effectively participate in and influence health policy at various stages. Need to know. Okay. So then we have another model. I think we have two more. Donovan's. I always say that name incorrectly. So let's look at the examples. So School of Nursing established a nurse-managed collaborative care clinic for non-insured patients with diabetes. 3 faculty members, 2 days a week, practice in this clinic. And then a lot of times in your community, check it out, they actually have these type facilities all over, where all the care that's provided is provided by professionals, but it's in kind, it's donated time. So you go in and, the doctor donates their time. The patient gets a full exam, everything. The nurse checks the blood pressure, do this, all of that, but it's through volunteer. I know a facility that we have been a part of that we take it a step further. So if that patient also needs medications and they don't have that insurance and no way of paying for it, then there is a chance for the community or whomever to donate. And so what they can do is we have these cards. They're like, those little cards, gift cards, and you can only use them at a pharmacy. And I don't know like how they prevent that, but anyways, that's how it works. And so that patient actually gets everything as though that they went in to the urgent care, to the doctor's office, to get all that care done. Now, of course, it's limited. Like we can't do like certain type of X-rays and things like that in the facility. They have to be sent out, but for the most part, they'll get everything just like they went in for a routine exam. So then process. The RN case manager assists patients to find free low-cost medications to manage their diabetes. We're seeing if there are any, especially if a person is on a medication like those new meds or one that costs a lot. A lot of times there are programs out there that pharmaceutical company might offer. There are some nonprofits that assist. And I just found out, you all, and I can't think of where it is. I'll find out for you all next week. But there is a nonprofit that in the event that there's a disaster, they have a pharmacy and they can get your medicine out to you. Hopefully, we don't be in a disaster area, but you just never know. And it's interesting to know their whole structure. And it, just imagine functioning in a disaster area. But I forget where they're based at. But nevertheless, I find out, and it is nationwide. And they're able to still get people medication in the event that there's a disaster. Because sometimes you got your medicines, you can't get to the pharmacy, but they have all those pieces of getting it, finding out, which medicines the person needs, and they have their own dispensary, and actually getting it, mobilizing it, getting it to the person. Practice manager monitors the following patients' metrics. Is their A1C less than 9? Of course, we don't want it to be pretty much above 5.7. No unplanned emergency department visits or hospitalization. So because we are helping this person this patient manage their diabetes, they're more that the A1C is trending back towards normal. And then they're not having to go to the hospital, for hyperglycemic episodes or anything like that because they're managing it well. They have a nice balance between food, medications if needed, and also activity. Okay, maintaining currency within the practice. Read widely and critically. Professionally accountable nurses keep abreast of their practice by reading journals. Remember, we're life learners and relating to their practice. Join a professional organization. There are professional organizations that you all can join. And for the most part, they are usually service-oriented organizations, but it keeps you abreast on what's the latest information. A lot of times they offer trainings. Remember, you're going to need those continuing education units anyways to keep your license current. Depending on what state you're in, depends on how many that you'll need. It varies. But these professional organizations, start looking at those. Attend professional conferences, participate in nursing research, patient-centered care, teamwork and collaboration. We're going to actually look at these here. Evidence-based practice, quality improvement and safety, and then informatics. Let's look at each one of these. Okay. So patient-centered care. This competency emphasizes we need to know recognizing the patient as the primary decision maker and providing care that respects their preferences and values. Patient-centered. Remember, our care plans are unique to that person, even though we have 3 patients that might have diabetes. It's still their care plan is going to be specific to them. What are their preferences? Where are their goals? One might be newly diagnosed. One might be diagnosed type 1 or either type 2. One might be type 2 and is having a hip replaced. So nevertheless, we are providing that care. The patient is making informed decisions because we've given them the information that they need. We're almost there, you all. Teamwork and collaboration. Did I skip one? Go back. Nope. Okay. Teamwork and collaboration. This competency focuses on effective functioning within nursing teams and with other healthcare, professionals, y'all, to ensure optimal patient care. We've talked about that, having the physical therapy and also needed to go to the doctor. You all should remember that teamwork and collaboration. We talked about that patient from day one, I believe. Someone read this slide for me. Let me hear from you all. Let me hear your voices. Evidence-based practice. Someone read for me. So out loud, come off mute and read for us, you all.
This competency involves integrating the best available,
I think you
evidence with clinical expertise and patient preferences to guide clinical decision making.
Okay, so we're just not pulling things out of the air. We have looked at the evidence and it's saying, hey, this is what we need. And also we're considering what the patient, what do they want? What do they prefer? Okay, quality improvement. Someone read this one for me. Thank you, Ms. Carter.
I got it. Quality improvement. This competency emphasizes using data to monitor and improve care delivery processes and outcomes.
Okay. So using the data to monitor and say, hey, this patient's getting better and or worse. Do we need to change this treatment for this wound? Because this wound, we're measuring, it is, this wound is getting larger. Or this wound is getting smaller, which is evidence of healing. We're looking at all those 3 measurements. Safety. This competency focuses on minimizing risk and preventing harm to patients and also us, and so we want to make sure that we're safe and that they're actually safe. Informatics. Let's look at the data. This competency involves information, technology, and then also decision making. The National League of Nursing aims to lead in setting standards that advance excellence in nursing education. So, who says that because we're taking this class, we need to be in this class, for 50 minutes, 105 minutes, 210 minutes, that along with that board of nursing, they set those standards and say that, hey, we need to have this many clinical hours, for this class, or no clinical hours for this class, or we can have some simulation or hybrid. We can have, both. How many observational clinicals do we need? So the goal applies to all levels of nursing education. The organization develops models and competencies that guides the nursing education. Okay, so quality, we talked about QSEN, quality and safety education for nurses. Who is it for? Future nurses. It prepares the nurses for quality and safety competencies. It defines essential knowledge, skills, and attitudes for nursing practice. So it focuses on 6 core competencies: patient-centered care, teamwork, collaboration, evidence-based practice, quality improvement, safety, and informatics. We just went through those. So these are designed so that, and the focus is, so these patients are patients that have the best outcomes, positive outcomes. And then so that it ensures that we're providing that best care that we can for our patients. And so we do have another 5-minute break. Of course, we have our 15 at the end, you all. But what we can do is, let me see if we do our, so that would be, wait a minute, that's not right. Hold on. So that means we do have, we can take a 5-minute break and then come back and then, and finish up. Yeah, let's just take a 5-minute break. Let's take a 5-minute break. So we will see you all. What time is it now? We'll see you at 10:06, 10:06, if you're Eastern Standard Time. All righty, come on back. So I appreciate you all. I knew you all were thinking good thoughts and that I would make it on and would be safe. So I think it's passed on. It hasn't completely passed over, but I think the worst has passed. So I know it was just me. I've had some others that were interceding and making sure that I would be safe. Thank you so much for that. I don't see any, looks like the lights and everything. Like I said, they blinked a couple times, but it looks like the name, everybody's okay. Don't hear any sirens going off. And so I'm gonna pause before we only have, we're gonna say we save the rest of our time towards the end. So we only have a few more minutes to spend together. And so I want to pause. Are there any questions about any of those concepts that we talked about? That financial piece is huge, but it's necessary because that's how facilities stay open. That's how facilities pay their staff. That's how facilities buy the supplies that they need in order to provide the care that the staff is called to provide. So I'm going to pause just think about it. Look at your notes, see what you've jotted down. Are there any questions about any of the information that we've went over so far? Any questions? Give you just a moment. To look and see. Okay, so I do need to hear from a few more people before we go. We probably, and I'll say my last little bit for the end. So I've heard from Davis, Carter, Chappis, and Shook Smith. So I need to hear from you all. Did you think I were going to forget? No, didn't forget. Okay, so volunteers, come on. Tell us about your top three. And if I need to put that slide back on the screen, I can, but you should have it jotted down. So let me hear from the rest of you. Let's go.
I'll go.
Okay.
So as far as my top three, I did hospital or like Maya Surgery Center because that's what I want to go into. The other two I picked was hospice and assisted living. As far as the organization, they have multiple providers, uh, residents, therapists, charge nurse, RN, LPN, aid for the hospital setting part of it. Things uh, that could be improved. I put positive attitude and patient organization. Um, I also put adequate staff, patience, and compassion for working in a hospital setting or a surgery center.
Oh, I did hear you. Thank you for sharing. Multiple providers. So think about in these, even in the assisted facility, was that one of your assisted living? Even in those facilities, not everyone has the same healthcare provider. There are going to be multiple healthcare providers that you're going to be working with. So it's not just a one size fit all. And so just know that in that compassion, yeah, this is, people, you're having to take care of people. And so it's going to take that compassion because things are not going to be how they were in skills lab. You already know that. You were here at the end, so that patient stayed position while we were trying to give that injection. They didn't ask any questions unless, we had the little doll on the simulation doll. We were asking questions, but, those were the perfect conditions. And so you have to have that compassion. All right, great. Thank you. Next person.
Yeah, I'll go.
All right, sure.
So mine are the emergency department or the ER. My second one would be hospice or palliative care, and then the other one would possibly be maybe correctional nursing or something like that. But my number one, of course, is ER. I just like the pace of it. I like the fast pace in it. The drive to help patients, and I don't want to have to uh like when you get them to where they're at, you still have to continue to care. I don't want to have to do. I want to be able to see them, get them in, help them what they need, and then be able to push them on to where they need to go next. You know, I don't want to have to build like those extra relationships with them. Nothing that not saying that I wouldn't mind it, but I just don't want to have to do that. Um, so of course, like uh Keisha said, same thing, you know, the roles in there, they have a director, they have LPNs, they have RNs, they have charge nurses, they have respiratory therapists, they have social workers. Of course, you know, registration staff in the front help get patients checked in and everything. They do that with the nurse beside them, so they have that. Um, Let me see what else is there. And then for better staffing, they just need better staffing to help them with their flows. I think that would help out a lot. And then also like with the ratios, you know, the nurse to patient ratios that help them staff if they staff better and then communicate well, you know, when it comes to certain drills or certain types of events that's happening within the department itself. And then a lot of them get burnt out a lot because of the staffing. So it's a lot of burnout in there as well. So that's mine.
Okay, thank you for sharing. I know in
Mhm.
our ER, we actually created, and you all may have it as well, and they may not call it this in your area, like fast track. So, you know, there are people that come in that, you know, you can take care of them. You know, it doesn't take as many steps. You can get them stabilized and they really can go on their way. But then, so they have like these, you're in the ER, but the ER essentially is divided up into like three different areas. So these are the ones that may be holding for transport. And these are the ones that you may be working in the ER on the fast track. So know that those patients are going to be quickly, you know, turning over because they're coming in, you know, to get that injection, you know, get that. But the one that's coming in that may need their nausea control, blood pressure is high, they're going to be the ones that's going to kind of be sitting there a little bit longer. You're going to be more interactions with them. You may have to give multiple doses of medications. You may have to start that IV or maintain or manage that IV. And then those others that we can't provide that care for, we're waiting to divert them or send them off to another facility. So that's a thing that they've created so that there's not so much burnout, there's not so much overload with that patient staff ratio within the ER. And of course, you know, staff is also cross-trained. That's another thing that all facilities, I think, do, especially hospitals. So you can actually rotate to the ER in the event that your main floor, your main area is well staffed. So just know that that's there. Now, there's usually some type of incentive of having to be pulled to the ER. So just know that. Have those conversations. Thank you so much. All right, next. I have time for a few more. I think we should get everyone. We should have enough time. Volunteer.
My
Yes, I
top
can go.
three. Oh,
Who, who was that, Miss Diaz or Miss Hunt? Who's
can
going
go
first?
first.
Okay, Diaz, who's going first? Go first. Okay.
My top three would be hospital, outpatient setting, and labor and delivery. As far as staffing, it's multiple providers, receptionists, medical directors, medical assistants, and I will say to help improve the work setting, it's to maintain the teamwork and communication.
Okay. Staffing just pops up everywhere, I tell you, but you all are going to lessen that burden. So yeah, so but we just encourage whomever else, you know, come on into the program, whether not this program or other programs, because it's a real thing, you all. The patient care, the load, and the staffing ratio. All right, thank you so much. So Ms. Hunt, I guess it's on you.
Um, my top three would probably be in home care, hospital, or family practice. My top one would be in home care. More because just like I just don't. That sounds harsh. I don't want to have to build relationships with like people because that's all harsh. And not that I don't want to. It's just like I like to get in and get out.
do what I gotta do, get it done, get on about my business. Um, I guess with staffing, with like in-home care, it is like, I guess it'd be like you and just your client, but with the staffing, it is short staff. I guess everywhere short staff, really. Um, it'd just be like with me being an LPN, it'd be like the RN over me, and then we'll be both working under like a doctor's license or a pharmacist license. But other than that, there's really no other staffing. Um, I don't know. I guess what could be better would be like the communication between the two nurses and with the client. Yeah.
Okay. So hopefully you all have, I know we have a few more. Hopefully you all have rotated or had the opportunity to rotate to these areas. Hopefully you have. If not, seek out someone that you can ask questions about the real. Miss Hunt, I will say, you said get in and out. You're in their home. It's gonna take time for them to trust you. Think about it. So you're gonna have to sit there and talk for a minute, and and then not to say, but because you made that comment, I just want you to let you know that because you're going into someone's home rather than going into their room at the hospital, which is a little different. In addition to that, you're going to have to put your creative hat on because think about it, you're in the home. Some things that you might have available in the urgent care or the clinic or the hospital, they might not have available. But that's good though, so that you can be creative and take what they have. And if it's workable and doable for them to have positive outcomes, yes. But then if not, identifying those resources, bringing that social worker on the team to help them to identify resources because that person may need a ramp. This person may need more lighting. So that may cause for an electrician to come in. Every time you go in, this person, something, may be out of place or whatever this person, so we can connect with a service that can come in and assist with whatever it is that they need. So it's a close that when I've rotated through home health and dealt with that in-home care, it was real up close and personal. You knew more than what you wanted to know because you were in their home. And then once you establish that therapeutic relationship, they just told you everything more than you ever want to know. So again, I encourage you also, if you have not gotten the opportunity to rotate to these areas, and as you listen to your coworkers, if you haven't thought about that area, it may hopefully, if it piques your interest, look into it because your top three might change because based on what you're hearing. All right. So who's next?
I'll go.
Okay. All right, listen it. Go ahead.
I choose hospital, long-term care / assisted living, home health care. My number one is long-term care / assisted living. I currently work in an assisted living. So I enjoy caring for older people and building relationship with the residents while, helping them to maintain their independence. The organization, you have the administrator, the DON, you have nurse manager, you do have RNs, LPN, CNA. That's it.
Okay. And that's another place too. They're so independent. They just need a little assistance. They can give you a run for your money. Like where is patient that lives in apartment A? They call them different things or room A or whatever. Where are they at? They're out and about. What'd you say, Miss Annette?
I said they refer to their home as their apartment.
Their apartments. Yes, that patient person that lives in apartment A, they're out and about. And, we're supposed to be checking their blood pressure or something. But yes, all these different settings, they're different. And that's another one too that you have to be creative with because you're in their home. And then home health, they're kind of waiting on you, but assisted living, what we found, sometimes they're not there when you're trying to go and do whatever it is that you need to do because they're out and about. Okay, next person. I think we have what, 2, 3 more. Do have enough time, so we should be able to get everybody.
I'll go.
Okay.
My top 3 is pediatric, adolescents, behavioral health, hospital like med surg and long-term care skilled nursing. My top is pediatric adolescent behavior health, which is what I currently work in. And I enjoy that because I like working with the kids and teenagers, and helping them through their difficult times and situations and being able to support them with their physical and emotional needs during, tough times. The organization structure there is basically the same DON, ADON. You got your charge nurses, um, team leads, and as well as RNs and LPNs. And then underneath them, you got the behavior techs. And what could probably make it better is more staff, more better communication, and more activities and stronger support for the parents.
I agree. I was gonna say I was thinking the same thing. More activities, and I don't know if we want to call them activities, but essentially that's what they are. Opportunities to talk through, work through, whatever it is. It's because a lot of times it's not. Most of the time, it's not that they don't want to do; it's just they don't know how to. And if we can create those times where they can, walk through it, talk through it, it just lends for better, positive outcomes. Okay, great, great. All right, who's next?
I'll go.
Okay.
My top three are psych nursing, correctional facility, and a hospital. My number one is psych nursing because I'm already in psych, so I'm already familiar with how it goes and like how it works. And like I'm experienced in that field already. And I love it. And I love my psych patients. Um, the the organizational structure in this setting is it's administration, the DON, nurse managers, supervisors, charge nurses, RNs, LPNs, uh, behavioral health technicians, therapists, social workers, case managers, and what I would say could help improve the setting would be like having a better balance of male and female staff, because it can help improve the safety and the mental health setting. Like some patients can become physically aggressive, and having male staff available can help provide like additional support during the situations that require physical intervention. Like, and then some psych patients, they'll have they'll have something against women, like something in their childhood happened with them, with their mom or their grandma or some type of female figure in their life, so they don't respond well to women. And like any facility that I've visited, even the one I worked at, it's mostly female staff. Like it'll be a 6'7" man who's aggressive and he needs to get IM'd, and meanwhile everyone there is under 5'5". So yeah, that's what I'd say will help improve.
Great point. All right. All right. Great, great, great. And so we've come to, and I know we have some people left. I'm not going to forget you. We're going to get you next week because we've come to our time that we have for break time. So you are free to go. But those of you that didn't present today, we're going to start off with you next week. You all take care. Thank you so much for pushing me through this storm. Thank you for sending up your words of safetyness and everything. We'll see you next week. Take care. Are there any questions, Miss Essence or Miss Annabella? You're free to go. It's break time. Miss Spellman, any questions? Miss Diaz, any questions?
So
All right, bye-bye.